So the next speakers are from the School of Nursing, two professors, Karen Dudersatd, who's a professor and has a PhD and has been working for over a decade, actually, in oral health and was a recipient of a CAN-Do pilot project from CAN-Do 1. This project is not actually a CAN-Do funded project, but is one that's the Elevate project, which they'll tell us about. And Professor Naomi Schapiro, also from the School of Nursing. And so they are going to be talking about a collaboration in the schools. So we talked about a project that was working in families, one that's working at the individual and microbiome level, and now one that's talking about working in schools, bringing us back to an earlier kind of paradigm that we saw earlier today of Fit for Schools. So with that, please welcome them for their presentation.
All right. Well, Naomi Schapiro and I are very happy to be here for School of Nursing, representing nursing, and also talking about the collaborations we've had with School of Dentistry for a period of time. As we introduced, it's definitely been over a decade, and we've definitely moved from global to local today. We'll be talking about a local project as well as our collaborations over the past number of decades. So I want to just say, of course, there's no disclosures, and also that the UCSF Elevate project that we'll be talking about has been a grant that was funded from Atlantic Philanthropies, and she'll tell you more about that. And also many thanks to our colleagues who may still be in the audience. I know Lisa is, but Bahar and Lisa Chung, and also Julie Goldman, who from School of Dentistry have been very integral in this project, and we acknowledge them and their work with us in the project. So some of the slides I can go over relatively quickly because of the information that we've had before, but I just want to reiterate from our perspective in working in the community that, of course, we continue to see significant dental caries by race and poverty in San Francisco and in Oakland, right here in the Bay Area. And again, it represents both a higher number in the Latino community as well as in the African American community, and in both age groups, 2 to 11 and 12 to 9. We'll be talking about sort of this middle school age group for the project today. And then again, for poverty status, and it's very clear that these bar graphs are very similar for poverty and race, and that's been presented earlier, that if you look at the poverty, less than 100% of federal poverty level and also over 200%, that there's a vast difference, and this continues to be true in the populations that we worked with in this project. So for oral health inequities, just to reiterate some of the other statistics that are evidence that's out there, 14 million low-income children did not see a dentist in 2011. 42% of uninsured children did not see a dentist within the past year. I thought it's interesting that this does reflect very similar to the maternal project that was just presented, I think 45% of women. So this represents very much, the maternal oral health represents very much that of the pediatric oral health. Poor children have twice the rates of untreated dental caries as higher income children. And also, again, as I mentioned, African Americans have a much higher rate. And then, unfortunately, in the most latest statistics that we looked at, they're continuing to increase in the adolescent population. There is a national shortage of pediatric dentists, and this is one of the ways that we've begun to collaborate and look at this issue of shortage across the Bay Area, and certainly talk about it nationally. So the prevalence of pediatric dentists nationally is about just under 4 per 100,000 of population. California is higher. We have a higher concentration, but still significant areas with very minimal access to pediatric dentistry. The numbers we have, and this may come up during the discussion if you have newer numbers, but around 650 pediatric dentists in California, and also a larger number of certainly health-allied dental professionals. Pediatric dentistry treat a higher proportion of children on Medicaid and CHIP than other specialties in dentistry, and 1 in 3 children in California is on Medicaid, so this represents a very large, needy population for pediatric dentistry and for oral health care. And also the demand for pediatric dentistry services is increasing both with Cover California and nationally with the Affordable Care Act. So the primary care knowledge gap in oral health care remains significant. Primary care providers lack competence in performing oral health assessments. I think that the frequent primary visits offer a great opportunity, particularly for nursing and nurse practitioners and other pediatric professionals, to educate around oral health and do oral health assessments. But there still remains this hesitation to incorporate that into an already very busy day, a very busy visit. But oral health, as we understand, is one of the key factors in health. So it's really, we need to look at this issue of lack of, the hesitancy and lack of knowledge. The role of nurse practitioners in oral health is incredibly important in the Bay Area, in California, and nationally. NPs can increase the access to oral health care services by implementing evidence-based practices, including some of the ones that were listed earlier, but I'll just go over those. The oral health assessments during primary care visits, and this is comprehensive assessment, oral health assessment, preventive oral health services, including fluoride varnish, and also timely referrals. I think many parents that I see on a weekly basis are still very surprised that we're asking them to establish a dental home by 1 year of age. So for those of us as pediatric providers, this is very common knowledge, but to parents, they still find this a new information. And certainly working prenatally is the first start with that in that really strong program that you presented. And NP collaboration can enhance the dental workforce's capacity to improve oral health outcomes in children and in adolescents. So furthering the role of nurse practitioners in oral health and primary care, comprehensive caries prevention under 6 years of age includes certainly oral health assessment beginning as soon as the teeth are up, all children established in the home, which I mentioned earlier, and then the most urgent need for referral are for those certainly with prolonged feeding, whether it's bottle or breastfeeding, particularly prolonged feeding throughout the night. And it is that substrate plus the very interesting presentations we've heard about bacteria that really builds the environment for increased early childhood caries. Again, the importance of the maternal oral hygiene and the incidence of maternal caries as being a major factor. And nurse practitioners in primary care, whether in family or pediatrics, can really be key in getting mothers into oral health and settings and providing and establishing a dental home. And then certainly higher incidence in low-income families and knowing that the risk factors are significant for those families. The other issue is just giving oral health education and modifying intake around the substrate of sugary intakes, frequent snacking, and also oral hygiene. The application of fluoride varnish, which we've been working on for probably 6 or 7 years with our students and training them for application. And this, one of the things that Naomi will also talk about is the fact that this is a reimbursable service to primary care providers and in school-based centers in 45 states for children under 6 years of age. And again, we've emphasized this in our training and education programs over the past number of years. But we thought it would be interesting to just pose that question. At the moment, the reimbursement, as we understand it, is under 6 years of age, so perhaps that could come up for discussion if it's an important piece to look at, pushing for reimbursement for this service, certainly for school age and adolescents as well. And I'm in clinical practice at San Francisco General weekly, and unfortunately, in San Francisco, I still see these kinds of dental caries on a regular basis, despite our good work, both at UCSF and San Francisco General in oral health care and oral prevention. Really, the brown spot lesions, white spot lesions I see very frequently. We do a lot of fluoride varnish up to every 4 months. And unfortunately, I see a number of these kids every 6 months, and that's just in being in practice part-time. So if you multiply that by all the providers, we continue, unfortunately, to see a large number of early childhood caries, which we know are preventable on so many levels. So there's more work to be done, I think, as we all know. So some of the national initiatives, which many of you may be familiar with for collaboration and interprofessional work, interdisciplinary work in oral health care. Certainly the IOM report was mentioned already, for the 2011 IOM report, which you mentioned. The Health Resources Service Administration, integration of oral health and primary care. This has been really key, the last 2 reports on this. The National Interprofessional Initiatives on Oral Health, which has also been a very key player in looking at interprofessional and interdisciplinary work. And then Naomi and I just came from a conference in Denver where we heard a really interesting presentation by some of the nurse practitioner faculty from NYU, and they were speaking about a number of interprofessional projects, actually 30 that they'd initiated across the state and beyond nationally, that have looked at improving oral health outcomes through using nursing and nurse practitioners in a variety of settings. So it was really exciting to hear nationally what a strong movement we have in beginning to impact oral health outcomes. I also just wanted to emphasize that we've had a long relationship with the School of Dentistry at UCSF. I know some of you may know Dr. Francisco Ramos-Gomez, and our work started together in 1995 and 1996 when we didn't actually use the term interprofessional at that point, but the Valencia practice, which we had, actually he rotated some of the dental residents and fellows through that as early as 1995 and 1996. I've been involved in 2 can-do projects, first also with Dr. Francisco Ramos-Gomez with early childhood caries, and then Dr. Abby Alcon, who was mentioned earlier, and her project with Can-Do on the oral health curriculum for child care centers and child health consultants. So that has been a really wonderful collaboration that occurred between School of Dentistry and School of Nursing. And then also, as I mentioned, integrating oral health into our curriculum several years ago. And oral health in early adolescence is the focus of the project that we're going to be talking about. And certainly early adolescents focus on appearance. So this focus on appearance and motivation is one of the opportunities to really be able to talk to them about improving their oral health habits. They have mixed dentition, their new adult teeth are emerging, so it's important to talk to them about lifelong health. And then also an important time just to modify caries risk behavior. So there is that early window of opportunity in early adolescence that you can really work with them readily on changing oral health behaviors. And particularly issues around improving access to fluoride, as I mentioned, application of fluoride varnish, working on oral hygiene, and then, of course, the substrate issues of sugar and acid and soda, and talking to them about the importance of healthy intake and increasing their water intake, which we've worked on very hard in the Oakland School District. And their previous care experience, many of them, if they were seeking care in the dental center, in the school-based center, this was one of the first times that they'd had a positive experience around oral health, and so that's a really important piece. And then also reducing salivary flow. And just briefly to talk about the triple aims that has to do with, certainly with the healthcare reform and the Affordable Care Act, improving the experience of healthcare, which for many of the youth in Oakland through the oral health program, we've been able to do that, improving the health of populations through preventive population-level interventions, which have been talked about early in the conference, and then also reducing per capita cost, certainly through student and faculty practice, through prevention, and through technical assistance to provide cost and effective and preventive care. So I'm going to then turn it over to Naomi to talk specifically about the project. Thank you. Mm-hmm.
Can you hear me? Yes, okay, all right. So this was our UCSF Elevate project. Elevate is a nationwide initiative funded by Atlantic Philanthropies in Baltimore, Chicago, the state of New Mexico, and Oakland, California. These were underserved areas, schools with high need, low academic performance, and also in communities with a history of activism. You can see this kind of swath in Alameda County. The schools in the Elevate project are highlighted in red, and just what's important about this project is that it cuts through the swath of West and East Oakland, which are medically underserved areas of Oakland with high poverty. These schools had either a renovated or brand new school-based health center with on-site dental operatory. We had nurse practitioner faculty who were embedded in the school-based health centers giving practice once a week. We also did a lot of technical assistance. Dental and nurse practitioner faculty would share best practices between clinics. And we had innovative service learning projects for nurse practitioner and dental students together. For example, interprofessional training and practice, our dental faculty trained pediatric and family nurse practitioner students in oral health assessment, enhanced caries prevention and fluoride varnish, so we varnished each other in skills lab. And then nurse practitioner faculty trained dental students in motivational interviewing and doing kind of client-centered counseling about health behaviors. And then we had joint dental and nurse practitioner student participation at screenings. We partnered with two of the federally qualified health centers who run the school-based health centers for what we called mass billable screenings, including oral health. So these were screenings in which either a percentage or all of the visits could be billed to increase the sustainability of the clinic. And because they were centered in schools that had health centers, if we came up with any kind of abnormalities, be they dental or high blood pressure or lack of vaccines, the kids could then be referred back into the clinic for care. So in the model, kind of the dental screen fluoride varnish model, Because nurse practitioners are not reimbursed at a very high rate for fluoride varnish, and we're not really reimbursed for kids over 6, this is a model developed by Native American Health Center where a bunch of folks do the risk assessment questionnaires. The dentist does the actual screening with a student because the dentist can get a very high rate for the screening. And then the kids fan out again to 4 or 5 varnishers, and all the kids get varnished by nurse practitioners, by medical assistants, by dental students and nurse practitioner students. And in this model, if even 10% of the kids are Medicaid eligible, the billing is enough to sustain the supplies and the effort and the screening for everybody. So, for example, in the 2012-2013 school year, in 1 week, 14 nurse practitioner students helped with screenings at 5 high schools covered by Native American Health Center with health centers, during which over 1,500 students were screened, 1,400 were varnished, and 1,600 were identified with urgent oral health needs and referred. And this was, with the addition of students, this is twice as many as could receive fluoride varnish from the prior year. And so it's a kind of a win-win, because for the nurse practitioner students, many of the situations in which they're going to be varnishing are going to be 6-month-olds, 2-year-olds, 3-year-olds, not happy about it, kind of screaming through the exam. And then they get to practice their assessment and varnishing skills on very cooperative middle and high school students. So it's a kind of a win-win for everybody. And then we also had some of the dental screenings connected to what we called Get Yourself Tested. This is a STD Plus campaign, so screening for STDs, but also making sure we were taking blood pressure, screening for body mass index, looking at immunizations, and then bringing the students back in for both oral health and regular health care. So the importance of these screenings were that we were able to increase access to the health center for kids who hadn't been there before, and then continuity because they could come back. We focused on prevention and oral hygiene. It was an increased intensive opportunity for oral health education and formation of early positive health habits. And also, many folks, me among them, are kind of afraid to go to the dentist. And we've had a lot of, intensive experiences. And this was actually a very positive interaction around oral health. And so we found that the young people were much less afraid to come to the dental clinic in the school-based health center if they'd already been through a screening and kind of a painless introduction. We also looked at a pilot for caries for Canberra, caries management by risk assessment. And so this is a program many of you are aware of, in which you assess for history of caries and current decay, presence of bacteria, diet and snacking behaviors and oral health practices, and then come up with individualized treatment plans. So we did a Canberra pilot project. This was developed by a dental student, Jolie Goodman, as part of a research project. We had IRB approval from UCSF and approval from the school site and clinic. We had... The clinic was part of the plan in the intervention. This, as far as we know, is the first known Canberra intervention in U.S. schools, although there have been Canberra interventions internationally. The site was an Elevate Project summer school program, and because it was summer school, there was somewhat more flexibility than during the school year. The school site, 89% of the young people were eligible for free and reduced lunch. The population was 72% Latino, 13% African American, 15% other, and we had multilingual families, not just Spanish, but also Arabic Karen, which is a tribal language on the border of Thailand and Burma, and Mam, which is from Guatemala and Mayan language. And we engaged in parent engagement consent events with nurse practitioner and dental students, helping out with the consents. We did a pre-screening, which was also multidisciplinary, looking at level of caries and the level of risk for future caries, and an individualized treatment plan based on that risk level. Then there was an intervention in the school in a health education class in the summer school for 1 month. So the clinic health educator and dental nurse practitioner and a public health student all helped out with this education in the classroom. They did daily brushing, xylitol, and if it was indicated, rinses. Indicated by risk level in the clinic for a month. Then at the end of the month, we did a massive day of food and raffles and brought in all of the parents to get individualized education from nurse practitioner faculty or dental or nurse practitioner student. They were delivered in Spanish and English and with other translation, and each family received their own bag of supplies. And then the home component was a month of daily activities, a calendar. If parents agreed, we text reminded them, post screenings, and returning and discussing calendars. So in order to have time for the conclusion, I'm going to kind of race through just to see that it was a small sample, 51 participants. Their risk of future caries was 78% at onset. 12% had not had a dental visit in the prior year, which is actually low. So this is actually in a group that had fairly good dental coverage. It was still 78% high risk for caries development. Most of them completed the questionnaires. Most of the parents completed the questionnaire. Students liked the dental products. Only 83% at 1 month, 100% at 3 months. Most found the camera management instructions easy to follow. They did increase their use of tap water over the study period, which in Copeland has fluoride in it. They increased brushing twice a day at 1 month, but not sustained at 3 months. And the adherence was much higher at school than at home, as we would expect. There were no changes in the plaque levels. The bacterial counts did decrease during the school phase, but then increased again in the home phase. So this, again, was mostly a feasibility study. So the strengths of the study were an enthusiastic response from the students, parents, and staff, more knowledge among students about the value of fluoride and xylitol. It suggests the value of an in-school daily preventive program and the feasibility of an interprofessional campus community partnership. The challenges were that we were unable to provide services to the whole family because we didn't have coverage to provide services to the parents and other kids, and we think that would have increased adherence. It was very labor intensive, so we do not know if it would be feasible during a very packed school year, and it was a pretty small N, so in the short run we were not able to show significant changes in oral health. So in the terms of the total project in our collaboration, in terms of the public health, the triple aims, we have been able to show that interprofessional graduate student service learning can improve care experience for early adolescents. And so, one of the ways to look is that can we do a much more interprofessional nurse practitioner and dental camera in the clinics? Improving the health of population students can also increase access to care. It's certainly helped in terms of experiential learning for the students about social determinants of health. And so the next steps might be a much more long-term look at what the benefits of mass fluoride varnish for early adolescents. And, would there be, we look at the long-term effects of community-based camera. I do want to say that several of the school-based health centers are now developing their own camera project. And in terms of lowering per capita costs of care, we helped with the sustainability at a critical time for these health centers. Sustainability funding is really decreasing for safety net providers under the Affordable Care Act because the idea is that most people will be covered, but in our community with a lot of immigrants, we're not seeing everybody covered, and that nurse practitioner and dental students can extend access and lower costs of outreach and preventive services. And the next steps will be a kind of post-grant analysis of the sustainability of this academic community partnership. Can we keep it up with a lot of grant funding? Tracking of costs over time, and kind of looking at kind of an extended view of care. And questions?